from BJ Medical College and then did my fellowship in surgical gastroenterology from Gangara Hospital, Delhi. So before I start, I just want to tell you that my today's presentation is based on these two articles published in Indian Journal of Gastroenterology in 2017 and 18. This is from chronic constipation in Rome 4 era, the Italian perspective, and then in 2018, Indian consensus on chronic constipation in adult. Both the primary author was Dr. Uday Ghosa, who is from SGPGI in Chandigarh. Lucknow. So chronic constipation is a common problem nowadays due to the lifestyle issue nowadays, change in the dietary habits, and also there is lack of adequate exercise, sedentary lifestyle, less water intake. So the incidence of constipation are increasing nowadays. Also the prevalence in India is range from 11 to 24% in different population of India, and it is more common in the female, particularly who is more child and that normal delivery more. Globally this prevalence is 14%. This constipation can be organic or a functional. So today we will more deal with the functional, discuss about functional constipation. So first let's see what is constipation. So last in 2016 the Rome 4 criteria was updated, and as per that the any of one should present for to label it as a constipation. It should be in more than 25% of the time of defecation or any one of these. Means if a person is passing 8 stool in a week, then it should be present in more than 2 stools. So if he has to strain, then passing lumpy or hard stool with Bristol stool form type 1 or 2. These I will tell you in next slide. Then sensation of incomplete evacuation, sensation of anorectal obstruction or blockage. If he needs any maneuvers like digital evacuation or to do any perineal pressure, vaginal pressure, or if you are then 3 spontaneous defecation per week. Also, loose stools should not be present in between. Now, Bristol stool form. This is Bristol. Yeah.
See, is there any criteria for straining? How long we will strain?
It's 30 minutes, sir.
30 minutes in the toilet?
Yes.
He should be in the 30 minutes toilet.
Yes.
Because some amount of strain every month we will be doing, to pass the stool.
Yes. So these are going to discuss detail. So this is Bristol stool form type. This is type 1, 2, 3, and then type 7 is a more liquid. Type 1 is a hard lumpy stool. But as per the studies, Indians does not pass this type of stool normally. Most of the Indians normally pass this type of stool because studies has proven that Indians have a faster colonic transit compared to the Western population. So Western population will pass type 3 stool normally compared to Indian population who pass type 4 stool normally. And this definition was for Western population. So for Indian population, they have revised and also included type 3 stool in a constipation type because of the faster transit time of colon in Indian population.
Yes, see, we Indians are having a lot of more fibers type.
Yes.
Compared to the Western. What will be the change in the stool if person is taking more fiber and if person is not taking? Is there any, can you make out that this is a less fiber stool and this is more fiber?
Yes, sir. Means less. Sir, this stool form is based on the colon transit time. Okay. Also the fiber included, but this is for the majority of the population compared to the Western. That's why Indians take more fiber. That's why we have normal Indians have type 4 type of stool compared to Western population. And also we have colonic transit time is our colon transit is faster than a western. So our colon transit time is 16 to 24 hours. As compared to western population, they have normal colon transit time of 36 hours. So fibers also play a role in this.
Another thing, any difference it will make if somebody is taking more water and somebody is taking less water.
Yes, it will make a difference. But sir, this is for a majority of population. You can't say
Because we are
yes, it will make a difference.
discussing different types of stool pattern. That's why these are the
Yes.
spontaneous question came in my mind.
But still, even if he takes more water, doesn't mean he will have a diarrhea. He will still pass a normal stool around this, and these three are all considered as a normal. Only this is considered as a blue stool. So type 3, 4 and 5, all this is the range of stool which can be considered a normal. But for an Indian patient, in Western they have included type 3 stool as a normal stool. And for Indian patient, we can't consider this type 3 stool as a normal stool. I just want to say this in this slide. We can't consider this as a normal stool. Otherwise, all three are normal stool. It can be type 5 also, type 4 also, type 3 also. Many are passing type 5 stool also normally.
In Indians, is the pattern same for all Indians, or it is rice eaters, wheat eaters, veg, non-veg, something like that?
Yes, sir. Almost majority are passing type 4 and type 5. And this study is from all Indian population, including Bangalore, Haryana, and East population. All are included. And also, if you look at this, in this there were around 29 or 31 authors are there from different parts of India, and they have accepted this. There are 29 sentences in this article, and all have accepted after this is published. And they are also from different part of India.
Okay, so next slide. Logically speaking, the upper diets are mostly seen in low fiber diet.
Yes.
The lower diets are mostly seen in
High fiber. Yes.
Logically, I may be wrong, but it is logical.
Logically આ છે, but આપણે જે છે મેજોરિટી પોપ્યુલેશન ને કન્સિડર કરીએ છીએ, તો હવે ઇન્ડિવિડ્યુઅલી તો દરેકનું અલગ હોવાનું જ છે. Okay. So in evaluation, always first we should look for the alarm features like age more than 45 years, if he has blood in stool or anemia, anorexia or weight loss, fever, abdominal mass, and GI cancer in family. Almost sometimes we ask all these features, but we forgot to ask about GI cancer in family, and patient will not reveal himself. So, and in early onset cancer, he might not have any of the symptoms previous, and he just have a family history which is significant.
So abdominal pain is not an alarming feature.
No, sir. Pain can be even in the functional constipation. He can have pain, and pain is also not an indication for malignancy or.
But it may be
And
indication of infection and something else, IBD.
Yes, it can be. But sir, my alarm feature is to exclude the malignancy, which should be treated immediately, and not to consider it as a chronic constipation.
But pain during feces is a alarming feature. That is what
Yes.
I would like to believe.
Yes, sir. And so for this particular article, what they mean to tell is that it's to exclude the malignancy as early as possible. That's why first this question should be asked to exclude if you see any patient of constipation. So to evaluate for the organic cause, we require colonoscopy, and if any feature suggests, then further evaluation by CT abdomen. So this was about the organic cause, just to exclude it. Now we will move to functional constipation. So most of the functional constipation are basically due to low fiber diet and low water intake. Many of the patients are because of this only, and they will be treated they can be treated with just an increase in dietary fiber and water intake. Other causes are like reduced bile acid. As we all know that bile is secreted from the liver and then go to small intestine, and 95% is reabsorbed from the terminal ileum. 5% passes through the colon. So this bile acid act as a purgative and it has an effect of laxatives. So when there is a bile acid malabsorption, we see a diarrhea, and when there is a low bile acid, it causes constipation. There is also a drug under trial in US market called Iliobixibat, but it is still not in a market. Then methanogens. There are some these methanogens will produce a methane in the gut, and this methane lead to slow motility and increase the colon transit. So with increased colon transit, there will be a constipation. Then low serotonin.
Any example of methanogen? Any food which contains lot of methanogen?
Food
Because some of the people do come, yeah, थोड़ा खा लो तो ये तो झाड़ो मत दो.
Yes.
The moment you say it, I ingested this for the last 2-3 days. I have been constipated.
I have not looked for it actually. There is bacteria, I forgot the name also, methanos, something like that, but I forgot the name. Okay, next in low serotonin, and it will also lead to slow colonic transit and fecal evacuation disorder. So today I will discuss more about this slow colon transit and fecal evacuation disorder. Other psychological disorders like anxiety, depression, insomnia, they are also associated with constipation. So again, here also history taking is very important to look for if he is suffering from any psychological disorder also. Then
Regarding low serotonin, I tell you that is sertraline, which is a serotonin reuptake inhibitor.
yes,
That drug is having incidence of diarrhea in 25 to 30% of patients.
Yes.
That's the way you say low serotonin. If you give in a depressed patient with constipation, if you give sertraline,
yeah,
it causes diarrhea.
Yes.
This is a effective drug for that depression.
yes,
Methanogen itself is a microorganism.
yes. There is a microorganism. I forgot
It's
the
not a
name.
substance, it's a microorganism.
Yes. So, as I discussed that the first line of treatment is increased water intake and high fiber diet. Sorry, this is spelling mistake. Studies have also proven that defecation in squatting position also helps to improve in the constipation. And also they have mentioned that Indian toilets are more physiological compared to the Western toilets because it relaxes the pelvic floor muscle and also puborectal sling that relaxes. Along with it, the first line of treatment should be osmotic laxative. It could be polyethylene glycol, milk, magnesia, lactulose, isabella, or lubiprostone. There is no any head-to-head study between two laxatives. Already good quality study, so we can't recommend that which laxative should be given first. But one criteria is there. It is that many of the constipation patients have associated complaint of abdominal bloating. Bloating is and also in Indian patient particularly, they have majority of the patient have associated bloating. So in this type of patient, isabella and lactulose should be avoided because they cause more bloating. Isabella is a husk seed called Plantago ovata, which contains soluble fiber, and this soluble fiber will increase the water content of the stool and form a bulky stool. But the fiber will get fermented and cause abdominal pain and also bloating. Same way, lactulose should also be avoided because it can also cause bloating. Sometimes patient come with a complaint of abdominal pain and bloating, and if we take a good history, then we come to know that patient is constipated and he takes isabella by himself only, and we treat him as a patient of abdominal pain. But what he requires is just switch from isabella to other laxative. So this should be also be taken in mind before prescribing this laxative. Now there are some food also. We just tell them to take a high fiber diet, but this high fiber diet are two types. High fermentable oligodimonosaccharide and polyols. This type of food can cause more bloating. So if a patient has a complaint of bloating, these all foods should be avoided. We just tell them to take a leafy vegetable and more fruits. But as we see here that apple, mango, even cabbage, broccoli, these are all high FODMAP food, and this can cause bloating. Also there is garlic, beet, cauliflower, mushroom, these all are high FODMAP food, and this can cause bloating. So when a patient has complaint of bloating, this type of foods should be avoided. We should tell them to avoid this. So these are the low FODMAP food. He can take these foods like grapes, maple syrup, orange, carrot, green beans. These are all low FODMAP food. So before prescribing a high fiber diet, we should also know about his bloating history, and if he has a high bloating, then we should tell them to take low FODMAP food. And so now basically the two features that
talk regarding the isopro. What about other 4, 5? You discuss only,
they are discussed because of bloating symptoms. So others, they don't have any head-to-head study that whether we should avoid particular in this or not, or any particular indication for this. They are all osmotic laxative. They all cause.
See, my mind is, a single individual, suppose constipation patient comes and I prescribe this approach.
Yes.
So how long should I wait for the result? And how long should I continue?
Sir,
And what is the thing? If a single individual, isopro is effective in how many percentage of patients?
percentage is around 46% for I say yesterday.
Out of this 5, which is more effective
And
and
there is no study about this.
my mind is, suppose it is 46%, what about polycyclic glyco?
That I don't know, sir, but I couldn't find any head.
Because this is a very common problem and we go on changing.
Yes, I also look for it that which one is better compared to other.
And what about combination of two?
Yes.
Sometimes you have to process it. Lubiprostone with polyethylene glycol.
Yes.
Lubiprostone with isopro. So what about if single individual agent is not effective?
This was also in my mind, and when patient comes to me, also I have a confusion that what to prescribe, and I look for this and many papers, but I couldn't find anything which can definitely say that which is better compared to other. That what all says is that prescribe first osmotic laxative. This is what that term, osmotic laxative. But they don't name which one is better compared to other. Also, there is no any particular study between the two laxative, head-to-head study, the comparison.
According to you, which of these more effective? You are guessing. I am asking you, which is more effective?
So, according in my experience, what I have seen is polyethylene glycol is more effective. But this is not any
Head-to-head trial.
or any proven studies from this. Is just my personal what I am prescribing from
In the
that.
extreme case, whether you have seen that movie Pushpak movie, where that Kamal Hassan every third day used to take enema. And that was the extreme case where
That case is due to fecal evacuation disorder, in which case a patient don't have a problem any in the colon. He has a normal colon transit time, stool reaches till the rectum, but patient is not able to evacuate from the rectum. That's why he has to take the enema every 2 or 3 days to empty his rectum, because he cannot empty his rectum. Otherwise, he is normal person.
Very nice movie.
So our problems are not discussed very much, not discussed frequently, and you find frequently in your outdoor patient.
મોટાભાગના ભારતીયોને આ પ્રશ્ન હોય છે.
પણ ડે ટુ ડે પ્રેક્ટિસ ની અંદર આ થાય છે કોઈ પોલીસ ટ્રાય કરે બીજાની પાસે જાય તો બીજું પ્રિસ્ક્રાઇબ કરે બીજાની પાસે જાય તો ત્રીજો ટ્રાય કરે.
So that's why at least we should look for at least we should look for, if we find some pathophysiology, we can treat it. So this is about a slow colonic transit time. Why slow and slow colonic transit can mean anything like a local factor like degeneration of interstitial cell of Kaji, visceral myopathy, autonomic neuropathy. If a patient is constipation comes to you with this and you prescribe anything, you will not get better. And we can't even know this situation without a biopsy. For that we need a colon specimen. We can't just resect a colon specimen to take a biopsy. So this is not in our hand. We can't do anything in this. Then some systemic diseases like diabetes, hypothyroidism, even hyperparathyroidism, you will have a constipation. Collagen vascular disease, amyloidosis, Parkinson, gut microbiome, I already tell you about mechanogenesis, then serotonin. Some drugs like opioid, anticholinergic, antidiarrheal, he may be on calcium channel blocker. Then this will also cause slow colonic transit. So if we, at least from the history we know about this, any of this from systemic disease or our drugs, we can tell them to switch if possible to switch the drug or better control of this systemic disease. Otherwise, in this type of disease we can't do. If he is on he has methanogen, then we can treat him with rifaximin. And now, how to evaluate this colon transit time? So this is just a simple and cheaper, and anyone can do it. There are radiopaque markers. We has to ingest, take orally 20 markers at the 0, 12 and 24 hours and do a X-ray at 36 and 60 hours. If there are 30 markers are retained in 36 hours or more than 14 markers are retained in 60 hour X-ray, then it is labeled as a slow colon transit. And this is a sensitivity of 99%. It is study proven. So we can just look at this, and also we can see that here in the ascending colon, descending colon, and here in rectum there are a lot of radiopaque markers are present. So he is basically low colon transit. Other tests are also that like radionuclide transit, colon manometry, smart pill is also there. But these are more costly and not everyone can do it. So just this X-ray technique will be much simpler.
So these radiologists are having this kind of marker.
Yes.
Readily available marker with them.
They come in a capsule. So,
Just this many capsules.
one capsule contains 10 markers. So you have to ingest 2 capsules at 0, 12 and 24 hours. So total 60 markers will be there. Out of 60, there is if more than 30 are written in 36 hours or more than 14 in 60 hours.
એટલે કોઈ કરે છે અહીંયા આવું કંઈ
અહીંયા તો બધું નહીં કરું.
અમદાવાદ
I don't think this is widely done.
એટલે સાંભળ્યું નથી એવું.
કોઈ નથી કરતો.
એટલે સર મેં ત્યાં
કોલોનોસ્કોપી એટલી easy થઈ ગઈ છે, લોકો આસાન.
Yeah, colonoscopy.
Okay, so the treatment for this slow colon transit is serotonergic, because this serotonergic will increase the colon transit time. The only effective which is working on a serotonergic drug is a prucalopride, which works effectively to increase the colon transit. Other drugs are high.
1 milligram and 2 milligram tablets. What is the name?
Sir, for people less than 60 years of age, 2 milligram dose is required, and more than 60 years of age should take 1 milligram. And it should be taken empty stomach in the morning.
Morning?
Yes. Then some high liquid propagated peristalsis. If the first line of drug prucalopride does not work, then we should prescribe this bisacodyl, sodium picosulfate and senna, because every drug has some tolerance after some period of time. If it takes daily, prucalopride can be taken for 2 years. After 2 years, it develops a tolerance, and then we will not have an effect.
How much percent it is effective?
Sir,
It is still effective. I use plenty of patients.
yes.
I use up to 2 milligram. I use it because sorry, I have to take even during night time because I have learned it should take even on empty stomach in the morning. But it is effective.
Yes. And then if due to methanogen there is a slow colonic transit, then treating with rifaximin and probiotic. This methanogen we can test with the breath test. There is a machine with a breath test. We can check for the methane level.
So this rifaximin in constipated patient is frequently prescribed by diabetes, to be frank with you.
Yes.
I have seen many prescriptions on diabetes of rifaximin.
So they have a fixed prescription for every patient.
Polytherapy.
One rifaximin, one probiotic, then one laxative syrup, and one metrozil.
So they maintain the gut milieu to avoid hepatic encephalopathy.
Yes.
Cirrhosis patient.
So now the next condition, fecal evacuation disorder.
Eight question here. I may be wrong in calendar, but metoclopramide and ordaxatron doesn't affect
No,
polar
sir.
transit, right? It
No.
affects only on upper tier.
Yes, sir. On lower GA only prucalopride is effective.
Etopride પણ નથી.
No. Tegaserpid and cisapride are effective on lower GA, but they are not available now. Now the next condition, fecal evacuation disorder. So it is just not able to evacuate from the rectum, which I mentioned. So patient forming a normal stool, it is reaching till the rectum, but is not able to evacuate. Why this happens? For that, let's know about the defecation mechanism. So when the stool reaches the rectum distance, so this distension of rectum sends a efferent impulse to a spinal cord, and from the spinal cord there is a efferent impulse to the internal sphincter, which will relax. Internal sphincter is not a voluntary muscle, so it is a smooth muscle, so it will relax. After that, stool comes down, and then a person decides whether he has to go to stool, and then he voluntarily relaxes the external sphincter and passes the stool. With this, there are other mechanism, like this is a puborectal sling, which creates an angle between a rectum and anal canal. So during the defecation process, this slings relaxes. That's why this angle becomes straight, and also the pelvic floor descends, and external sphincter relaxes, and the person can pass the stool. So if also there is a contraction of the abdominal muscle, this abdominal muscle will cause an increase in intrarectal pressure. This again will lead to efferent and efferent impulse. So this is the mechanism. So if there is a problem in any of this mechanism, it will lead to a fecal evacuation disorder. Like if he has a mega rectum, then the rectum will be large, so he requires a large quantity of stool to send a efferent impulse. So he will not pass the stool in 1 or 2 days. He will require more quantity of stool. Another thing is the rectal hyposensation. If due to any condition he has not a good sensation of rectum, then also he will not pass stool. Next is rectal neuropathy due to any cause. Then this pudendal nerve is supplying the external anal sphincter. If this nerve is damaged due to any cause like trauma, surgery, childbirth, chronic constipation even can lead to damage or repeated stretching and damage this pudendal nerve. So he will not be able to evacuate. Also during the childbirth there is damage to the internal or external anal sphincter, and then she may not be able to evacuate. Also spastic pelvic floor. In this spastic pelvic floor, even the patient will not able to pass the urine also. So for the evaluation, meant to suspect at least he has a fecal evacuation disorder, that he has to strain in toilet for more than 30 minutes, then passing stool in a different posture. Then patient usually sits, again stands to create some pressure, again he sits, and he has to pass in different posture. If he needs any manual evacuation, if he has to push his lower abdomen, vaginal, or do any perineal pressure, or if the constipation is after a difficult delivery, then we should also suspect it as a fecal evacuation disorder. So the first examine with the rectal examination, good rectal examination can tell you about this. Look for a resting sphincter pressure, which is from the internal anal sphincter. Then ask the patient to squeeze, which is from an external anal sphincter. Then ask the patient to defecate. If he can while defecation, sphincter should relax. Then feel for tuborectal sling if it is relaxing or not. Then presence and consistency of stool if it is a hard or smooth stool. And also with along with the PR examination, put other hand on the abdomen to look if there is abdominal muscle contraction is adequate or not. This comes with if we look for every patient, then with experience also only we can come to know whether it is adequate or not. This is a balloon expulsion test which can be done anywhere, and even in the OPD we can with this simple test we can assess the fecal evacuation disorder. You can take infant feeding tube and over that tie a condom and insert it inside the rectum. Then inflate this condom with around 60 ml of saline and ask the patient to evacuate it normally. If the patient is not able to evacuate, then we can also put some weight to assist him. If he requires more than 250 gram of weight, then it is called as a fecal evacuation disorder. If less than 200 gram is required, still it will not be considered as a fecal evacuation disorder. Now to confirm this, there is an anorectal manometry. With this, all these we can check resting sphincter pressure, squeeze sphincter pressure, length of high pressure zone, rectal inhibitory reflex, this reflex which I told you about, rectal sensation compliance. Vector manometry is a different thing in which along with the pressure we can also see the direction of the pressure, because if the sphincter is damaged from one side only, then in anorectal manometry will be normal because it measures only average pressure of all the muscles. So vector manometry will see also direction of the pressure, so we can identify a patient who has a partial damage to a sphincter. Other investigations are
How you can do it?
Sir, there are two catheters inserted in the this sensitive catheters are there, which are inserted in inside the rectum, and we ask the patient to do squeezing and all this movement, and machine will record it as a bar of a pressure, just like a esophageal manometry. It will record this bar, pressure bar. So other investigations are endoscopic ultrasound. With this we can look for external and internal sphincter, tuborectalis, levator ani, and all this pelvic floor muscle. Then difficography. Difficography we see a defecation process dynamically in a MRI or under fluoroscopy. Then anal sphincter electromyography and barostat. Barostat is for a rectal sensation. If patient has a low rectal sensation, then this is better than an anorectal manometry. So obviously the multiple test has better accuracy than a single test, because as I mentioned that partial damage to sphincter will not be picked up by anorectal manometry. So this is to be decided by a treating physician what investigation he wants to do and which is best for this patient. So treatment for this fecal evacuation disorder and best is biofeedback therapy. This biofeedback therapy is a retraining of a sphincter. So it is just like a patient has forgot to pass the stool and he is now learning how to pass the stool, how to act the muscle. So it is good to have a good rapport between patient and therapist, just like a teacher and a student, to learn how to pass the stool. Patient from the manometry result only, patient is given visual and auditory feedback after every time he passes the stool. He for this he comes to a hospital, and or if he has not passed in stool, we can also give him an artificially created stool, insert it in the rectum and tell them to pass the stool. Along with this, we record their visual and audit and give them a feedback that what he is doing right and what he is doing wrong, so where he should improve. So if good biofeedback therapy is done, then benefits are long lasting. Now the last is surgery. When we require a surgery in this type of case, obviously organic cause we require surgery. Then slow colonic transit. When it is refractory to drug, or over a time it has become drugs are tolerant or become ineffective, or there is extremely slow colonic transit time, then we don't have any option other than to resect the colon and just do a ileum and rectal anastomosis. With this, we can also have a sample for a colon specimen, and most of these patients are found to have neuropathy, myopathy, or this degeneration of interstitial cell. Then next condition is rectal prolapse. Majority of rectal prolapse have a redundant sigmoid colon also, which leads to constipation. So while treating the rectal prolapse, we need to resect for the sigmoid colon, so he should not get a constipation. Also after the surgery for rectal prolapse, some patients are developing the constipation. This is because posterior rectopexy is there. Generally rectum is attached to either posteriorly or anteriorly. So nowadays surgeons are doing more anterior rectopexy to avoid this, and then this Ogilev syndrome, which is an acute pseudocolonic obstruction. Most of the patients with chronic constipation will get some acute attack in between, like this, with acute colonic pseudo-obstruction and has a hugely dilated colon. We can treat him for conservatively for 24 to 48 hours maximum, or try a colonoscopic decompression. But if it doesn't resolve, then we have to do a surgery and resect this dilated part. So to conclude this, again, history is very important in the management of constipation, because if we know at least that what is the pathophysiology behind it, then we can prescribe him as a good treatment which is best for that patient. Organic cause should be excluded first. First line of therapy is increased water intake, fiber diet, and osmotic laxative. When the patient is abdominal bloating, then we should avoid high FODMAP food and isabutol and lactulose. Slow colon transit is first treated with glucalogride, and fecal evacuation disorder is treated with biofilm.